NPs, or nurse practitioners, often referred to as super nurses. They are nurses with a more extensive training and a broader scope of practice. All over the world, including in Canada, they're seen as a way to increase the performance of and access to our healthcare system. As part of a research project of the Pocosa Research Chair, and with a collaboration of nursing students at the nursing faculty of the University of Montreal, we collected data from all 10 Canadian provinces to try and see what NPs actually do. We looked at two major dimensions, one that concerned supervision and level of training, and a second concerning scope of practice. The first dimension was divided into three sub-dimensions. First, are NPs supervised by physicians? If so, is this a formal or informal supervision? Secondly, how long must they study to get their diploma? And thirdly, how long is their internship? The second dimension was subdivided into four sections. The first being, can nurse practitioners order tests? If so, which ones? And are they authorized to interpret the results? Secondly, same thing for prescription drugs. Can they prescribe only a select few, or do they have access to a more complete list? Thirdly, can they refer patients to a specialist? If so, under what conditions? And finally, can they register patients under their own name, or do they have to be registered under the supervising physician's name or clinic? When we look at the broader picture of Canadian provinces, we notice large differences. Certain provinces have a scope of practice score that's nearly perfect. These include Nova Scotia and Manitoba. And in terms of supervision and control, they are fairly low, so NPs have a broad scope of practice with relatively little supervision. Other provinces have a perfect score on 3 out of 4 subdimensions of scope of practice: Ontario, New Brunswick, and Alberta. Ontario is an interesting province to look at. They were the first to introduce NPs and is the province where there are the most NPs by far. Scope of practice there is very broad. Medical supervision is limited and NP training is relatively short. In Saskatchewan, British Columbia, and Newfoundland, scope of practice is also very broad, but there is a significant medical control over NP practice. Finally, there are the provinces with the least interesting deployment plan: Prince Edward Island and Quebec. Quebec stands out particularly for having the lowest possible score on not one, not two, but all 4 subdimensions of scope of practice. No other province imposes such limits on NP practice. Another interesting point: despite a limited scope of practice, medical supervision is very high, and it is also the province where NPs have the longest and most comprehensive training. Through the picture we've presented here, we see that there is a very weak relationship between the breadth of supervision and scope of practice. A second extremely important conclusion is that all these NPs don't have the same worth. For example, if we give a broad scope of practice to an NP, she'll contribute much more to population health than an NP with strict limits on her practice. An NP in Manitoba is allowed to do much more than an NP in Quebec. Therefore, when we talk of deploying NPs, we can't simply consider how many nurse practitioners to deploy, but also what they are allowed to do.